Primary and Secondary Survey of the Burn Patient, written by Sheila Giles, the Nationwide Children's Hospital, presented by Andrea Bigley, the OSU Burn Center. The objectives of this are to be able to identify the principles and the uniqueness of the primary assessment of the burn patient. They'll also be able to identify the principles and the uniqueness of the secondary assessment of the burn patient. So what is concerning with the primary assessment of a burn patient? Nothing different than a trauma patient. We're still worried about airway, breathing, circulation, disability, and exposure. The principles of this care, ABCs, are always going to be your primary assessment. The tissue damage is the lowest priority. Please do not let the burn distract your assessment. You may need to repeat the assessment frequently to identify changes in the patient's status. When assessing the airway, what you're looking for is airway patency. You can open the airway using the same measures you do for any other trauma patient: chin lift, jaw thrust, protecting the C-spine if that's a concern. Always consider intubation if necessary. We want to do that earlier rather than later. Breathing is another thing we're concerned with. Assess the breath sounds, rate, depth, quality. Administer 100% oxygen with a non-rebreather if you have any concern for an inhalation injury. Encourage the patient to cough and deep breathe. Suction is needed. Position the head of the bed up if possible. You want to assess the chest. Does it rise and fall? Do they have good symmetry? In the presence of a circumferential burn to the chest, you may have some problems with excursion. It could be altered. So if that's possible, or if that comes up, please refer to the circumferential module for treatment on escharotomies and fasciotomies. Remembering that an asymmetrical chest excursion could also be related to a trauma, so please make sure you're assessing for any related traumas. Circulation is another concern. You want to assess all the peripheral pulses. If it's compromised, it could be due to a circumferential extremity, so make sure you're keeping that in mind. Burns also develop a lot of edema due to that capillary leak. So we want to elevate those extremities whenever possible. Remembering your trauma protocol, the 2 large bore IVs still applies here. Lactated ringers is the preferred solution. However, normal saline can be given if lactated ringers is not available. You want to assess the cardiac status. You can use the blood pressure cuff on the burned extremity if you need to. You might need to Doppler the pulses due to some of the edema formation. Disability is another thing you're going to be assessing for. You could use the mnemonic AVPU, looking for alert, response to verbal stimuli, response to painful stimuli, unresponsive. Generally speaking, burn patients are awake and alert. If they're not, a couple other things should be considered. Things like head trauma, hypoxia, intoxication, or they could have chemical compromise from like inhaling things in a burning building, could give them a decreased LOC. Exposure and environment. You want to ensure that all the clothing, jewelry, metal, diapers are all removed so that you can fully assess the patient. Jewelry should be removed so that you don't end up with any tourniquet formation, especially things like wedding bands or other rings. You want to keep the patient warm, covering them with dry sheets, warming your resuscitation fluids. You could increase the room temperature if possible to help keep the patient warm. In the time of an emergency, you may not always have all of the best supplies available. Some things could be used like cotton diapers, cotton t-shirts, white cotton gloves, sanitary pads to cover burn wounds in a disastrous situation. The secondary assessment on the burn patient. So what are we looking for? Same thing you'd look for on any trauma patient. You want to obtain the history, their medical history, their circumstance of injuries, the consideration for any inhalation injury. You would do a head-to-toe assessment. We want to obtain a weight, the weight we use for fluid calculations, and so we want to make sure we have an accurate weight whenever possible. It's during this time that you'll also determine the total body surface area that's been burned. At this point, we'll also start to determine the fluid resuscitations that this patient's going to need, and you would develop some pain management protocols. Labs, Foley, and a nasogastric tube should also be considered at this time. So in the medical history, what are we looking for? Same thing you'd look for in a trauma assessment, where you use the mnemonic AMPLET. We want to know about their allergies, their medications, their drug and alcohol use, their past medical history, any pre-existing diseases, their last meal, the events, and any tetanus status at this point. So the circumstance of injury, there's a couple things that we're specifically looking for related to burn injuries. How did it occur? Any toxic chemicals involved? Were they inside or outside? Was there smoke involved? Was there any type of explosion? And is the patient at risk for falling or being thrown or blown? So when we talk about how it occurred, I mean, we want to know, was there an explosion? Did the patient get thrown? Could there be shrapnel that we would be concerned with? Were they inside a building where there's lots of smoke that they inhaled? Or were they outside, and so the smoke is probably not a factor? So we want to know where it happened and how it happened to give us a better idea of what injuries to assess for. In the consideration of an inhalation injury, there's about 3 types that we're the most concerned with: carbon monoxide toxicity, upper airway injury, lower airway injury. Carbon monoxide has a risk of making the patient hypoxic. So what happens is that carbon monoxide binds to the hemoglobin molecule. The hemoglobin molecule normally carries oxygen in your bloodstream, but now it's carrying carbon monoxide. It bumps the oxygen off and then saturates that hemoglobin molecule with carbon monoxide, so it floats around in your bloodstream, and then it causes tissue hypoxia. The treatment for this is 100% humidified oxygen. Now, not all of us have the luxury of having humidified oxygen, but 100% oxygen is really the goal. What will happen is that the oxygen then supersaturates the bloodstream and knocks the carbon monoxide off because it goes away pretty fast. The half-life, and I can't remember the numbers specifically, but it's very fast. Within an hour, it's almost going to be back to goal. It'll be all knocked off at that point. When we're assessing the patient, the pulse oximetry is not a useful tool. The pulse ox measures the capillary saturation of the hemoglobin molecule. The hemoglobin molecule is currently saturated 100%, but 100% with carbon monoxide. So that's not going to be an indicator of what you would want to look for. The carboxymethemoglobin lab value is the one that you'll want to check to monitor those levels. What are the effects of carbon monoxide? The patient can complain of a headache, pulsating temples, flu-like symptoms, nausea, vomiting, agitation, decreased level of consciousness, seizures, difference in Cheyne-Stokes respirations. The cherry red skin color is not very common in the burn patient because most of the patients in a true smoke inhalation scenario are covered in soot. Or they may not be covered in soot, but they don't look really cherry red because of any other burns or skin issues. What you will find, though, is that they look and act a little bit different, a little confused, and so it sometimes confuses people with drug and alcohol intoxication. So that's where we have to remember, where did the patient come from? What was the scene? This table shows the levels of carbon monoxide and the actual symptoms that you might consider. When it gets up to the 40 to 50 level, you're going to have some very, very sick patients. Increased heart rate, increased respirators. They could have seizures. They could go into a coma. Upper airway injury, on the other hand, is when patients inhale superheated air that can damage the tissue of the upper airway and then cause subsequent swelling and airway obstruction. So that edema forms over the airway and cuts off their airway. These are the patients we would rather intubate sooner rather than later. It's a lot easier to intubate before the swelling starts. Then we can allow the swelling to run its full course, and then we can remove the tube without any incident. If we miss this assessment, the patient will require a crike. Lower airway can be a slower progressing injury. What will happen is the patient can inhale toxic chemicals that then damages the lung tissue. And so then it's usually 12 to 24 hours later where the inflammatory response has created so many secretions into the lungs that the patient can't oxygenate themselves well because they can't get rid of those secretions. These patients require intensive pulmonary toileting as they have copious amounts of secretions that require a lot of suctioning. Continuing with the head-to-toe assessment, we're still going to be looking for critical physical findings. Does the patient have singed facial hair, eyebrows, nasal hair, soot in their mouth, carbonaceous sputum? We're going to assess them fully by inspecting, auscultating, and palpating all the body areas, looking for some edema formation that's making the burns feel very tight, assessing their pulses. You'd want to log roll them, make sure you're noting anything on their backside and any other abnormalities you might find. What we're looking here is for the associated injuries are going to be our highest priority. You'll see some other things with explosions that you wouldn't normally find in a normal burn patient that came from a house fire. So you want to make sure that you're looking for areas of shrapnel and other things like that. We also want to continue to assess their level of consciousness. It's important to note that within the first 24 to 48 hours, if a patient dies, it's generally related to their associated injuries, not related to their burn injuries. So we don't want to miss anything. We want to make sure we're obtaining a weight. If we can, we need to get the patient's weight in real time. However, in a disaster situation, we may not have the luxury of a scale, and so a guess or an estimation will do. We use this weight to calculate their fluid resuscitation needs. We also need to determine their total body surface area involved. You can use the rule of nines, which is a way to determine the body size. So in the rule of nines, a right arm, for example, if it were burned all the way around from the top to the bottom and all the way around, would be 9% of that patient's body. If the right leg in the front or the anterior surface was burned, that would be another 9%. So that patient would have an 18% burn. However, not every patient is nicely burned in just one area, and they might have scattered burn areas. The Palmer method is another method that could be used to figure out the percentage of burn. You take the patient's palm, including their fingertips, and that's approximately 1% of their body. You use that size to determine the scattered areas to figure out their total body surface area burn. So to calculate the fluid resuscitation needs, we recommend you use the Parkland formula, which can be anywhere from 2 to 4 mLs, and then the patient's weight in kilograms times their total body surface area. You're going to take that calculation and divide it in half, and that half of the fluids you're going to give in the first 8 hours from the time of the injury. And then you give that other half over the next 16 hours. You're going to evaluate the effectiveness of your fluid resuscitation because you've placed a Foley and you're going to monitor the hourly urinary output. The urinary output is the gold standard to measure fluid status, not the heart rate, not the blood pressure. The desired output is 0.5 mLs per kilo per hour, or approximately 30 to 50 mLs per hour. Here's an example of a fluid resuscitation. We have a 35-year-old male with a 30% total body surface area burn. He weighs 100 kilograms and he does have an inhalation injury. So you would take the patient's weight times their total body surface area, and we're going to use 3 because he's going to need a little bit more fluid because of his inhalation injury. And that's going to give you 9,000 mLs. That's what you're going to need to give over the first 24 hours. So we're going to take that number, divide it in half. That's 4,500. That's what you give in the first 8 hours. So if you divide that by 8, it gives you a number of 562. The 562 mLs is what you're going to set your pump at for the first 8 hours. Now, do we set it and leave it there? No. We set it, and then we assess our patient the next hour. How's their urinary output? And then you would keep assessing that patient every hour. It's a starting point. Parkland formula is a starting point. It is not the only thing you consider. You want to look at what's happening to the patient and treat the patient. Other things you might consider: get some initial labs. Get a CBC, electrolyte, glucose, BUN and creatinine, and a carboxymethyl if you're worried about an inhalation injury. CBC, you're looking for an H&H, maybe a white count just to see where they're at, but the CBC is just to get some baseline assessments. Electrolytes, same thing. Get the baseline, make sure we don't need to do anything to change, is their potassium okay? How are they doing? Glucose, same thing. And the BUN and creatinine, we want to make sure that they have good renal function for their fluid resuscitation. If they have any renal impairment, we would need to know that sooner than later. Other considerations: you might want to place an NG tube if a patient has a greater than 20% burn or if they're intubated. We want to make sure that we don't have any problems with aspiration. Pain management is another concern. You want to give small, frequent doses of narcotics IV if you're giving fluid resuscitation or if they have a very large burn. You have to keep in mind that the absorption of subcutaneous or IM injections are very unpredictable, and IV or PO pills are the ideal rate or ideal administration. Patients with the small burns can actually be managed with oral narcotics. Anti-anxiety medications should also be considered, as it does help with pain management. Reassessment. Constant reassessment is a priority in a burn patient. We want to continue to assess their ABCs, using vital signs, assessing their pain, and monitoring their circumferential burns if they have any. So in summary, the primary assessment of a burn patient has unique elements which may impact adequate oxygenation. Close monitoring of the ABCs while maintaining a warm environment is a critical intervention in the beginning stages of a burn assessment. Secondary assessment fundamentals include screening for inhalation injury, head-to-toe evaluation, calculation of total body surface area, and effective resuscitation delivery, appropriate labs, and pain management all benefit the patient and getting them back to where they need to be.